Hello and welcome. On behalf of CME Outfitters, I'd like to welcome and thank you for joining us for this program titled EGPA Management, Integrating Targeted Therapies to Optimize Outcomes. This program is part of a CMEO snack series supported by an independent educational grant from GlaxoSmithKline. I'm Dr. Michael Wexler, Professor of Medicine and Director of the National Jewish Cohen Family Asthma Institute in Denver, Colorado. Today, I'm joined by Dr. Philip Siow. Phil?
Hi, everyone. I am the former director of the Johns Hopkins Vasculitis Center, where I've cared for patients with ANCA-associated vasculitis, including EGPA.
Well, it's great to have you, Phil. I'm looking forward to an engaging discussion. So here are our learning objectives for today. Our major goal is to try to integrate treatments for EGPA based on current guidelines and patient-specific factors. Really, when we think about treating EGPA, I think it's important to step back and ask, what are the goals of treatment? First of all, it's critical that we induce remission in all of our patients. And we also want to try to avoid and reduce any potential for relapses in our patients, where patients need to have any additional therapies or increasing doses of corticosteroids for disease management. Obviously, for our patients, we want to try to prevent organ damage and dysfunction of any organ, as well as any related morbidity and mortality. Because this disease often requires immunosuppressants and corticosteroids, it's critical as well for us to avoid or limit the toxicities of the treatment for this important disease. Lastly, from a patient perspective, we all want to make sure that we can maintain or enhance the quality of life for our patients. So, Phil, why don't I ask you, what are your strategies and what are some of the guideline-based strategies for inducing remission in our patients? What do you utilize for induction therapy?
So the first thing I'll mention is the way rheumatologists think about the treatment of vasculitis just in general is in terms of two different phases. We talk about a remission induction phase where you get the patient to be in remission. And then we talk about a remission maintenance phase where we use less aggressive medications to keep a patient in remission. So with that approach, when we think about remission induction strategies, we really think about patients in terms of severe versus non-severe disease. Severe disease is what we think of as threatening life or the function of a vital organ. So the manifestations you most commonly think about in vasculitis are things like pulmonary hemorrhage, glomerulonephritis, and mononeuritis multiplex. It's those patients that really get treated with our most aggressive therapies. The patients who have non-severe disease, where they don't have life-threatening manifestations, they're treated with a broader range of options, and we can certainly talk about that in just a moment. But for patients with severe manifestations of vasculitis, treatment really focuses on two different therapies, either cyclophosphamide or rituximab. Now, cyclophosphamide is the drug that we use when we're the most confused by a patient, because cyclophosphamide is the drug that we have the most experience with. So cyclophosphamide for decades has been standard of care for the treatment of severe forms of vasculitis, and especially in a patient who has multiple serious organ involvement, especially cardiac involvement. You certainly want to think about using cyclophosphamide up front.
To clarify, Phil, I just want to make sure we're talking about on top of corticosteroid treatment as well, correct?
Yes, absolutely. Rheumatologists love corticosteroids. There's no way we're ever going to come up with a treatment algorithm that doesn't involve a substantial dose of corticosteroids in the background. So with regards to cyclophosphamide, we will certainly use it for cardiac manifestations, but we'll also use it for other serious organ manifestations as well. The issue is that cyclophosphamide is associated with significant organ toxicity. We talk about the risk of bone marrow aplasia, bladder cancer, serious infections, infertility, and other issues that occur when patients are treated with cyclophosphamide, even though these are less common in patients who are treated for the short courses that we use nowadays pretty standardly. But because of the concerns of cyclophosphamide, we're certainly using more rituximab for the treatment of these serious manifestations. Now, rituximab may not make intuitive sense because it is a B cell strategy for a disease that's really mediated by eosinophils. But at the end of the day, our clinical experience seems to demonstrate that if you have a vasculitic manifestation like pulmonary hemorrhage or glomerulonephritis, rituximab seems to work pretty well for patients who have got EGPA.
And when would you use rituximab? You said it's a B cell therapy. So is it that reserved mostly for patients who are ANCA positive? And what are the data for utilizing in that patient population, in patients with EGPA specifically, as opposed to other ANCA associated vasculitides?
Yeah, for the use of rituximab for EGPA, it's kind of interesting the way that it's evolved over the years, because for many years, rituximab was one of the few biologic therapies that we actually had access to for the treatment of vasculitis. So I think we gained a significant amount of experience just based on clinical use. The recommendations are generally that you consider using rituximab specifically in patients who are ANCA positive, who have vasculitic manifestations. So again, you think about someone who has pulmonary hemorrhage or glomerulonephritis or mononeuritis multiplex, the manifestations I might see in any patient with vasculitis. Specifically with EGPA, I think the data are more limited, and we certainly have case reports and case series supporting its use even for things like cardiac manifestations in EGPA, but I can't point to a randomized controlled trial that demonstrates that. For patients with non-severe manifestations, really the question becomes, what type of flavor do you get from the patient's organ involvement? For patients who have vasculitic manifestations like purpura, for example, you would think about medications that we typically use for other forms of vasculitis, drugs like azathioprine or methotrexate. And the reason why I specify that is because a lot of patients you're going to meet with EGPA are going to have non-vasculitic manifestations that predominantly affect the respiratory tract. And for patients who have got, say, severe asthma or chronic nasal polyposis or sinus involvement, they're not necessarily going to have as good of a response to conventional immunosuppression. And for those patients, I might not reach for methotrexate or azathioprine right off the bat.
So how do you decide, are there any patients in whom you can give corticosteroids alone? And what would be your treatment strategy and algorithm in making that decision?
Sure. So rheumatologists often think about something called the five-factor score, which was developed by the French Vasculitis Study Group based on their enormous database that they've created over years of conducting clinical trials in ANCA-associated vasculitis and in polyarteritis nodosa. So what they did was they created a prognostic index. They took all the data that they've accumulated from all their clinical trials, and they tried to figure out which factors seem to influence mortality. So what they came up with is the five-factor score. So the five factors are age greater than 65, cardiac insufficiency, renal insufficiency, gastrointestinal involvement, and ENT manifestations. And the first thing I need to let you know is that ENT manifestations is what we call a negative factor. So it cancels out one of the other factors on the list. So for example, if you are 70 years old, but you also have ENT manifestations, then your five-factor score is 0. And a five-factor score of 0 is great because it has the best prognosis. Having a five-factor score of 1 is where things start getting more serious. Those are the patients who really need to be treated with more aggressive therapies because they have a higher mortality. And in fact, the 5-year mortality for a patient with a five-factor score of 1, regardless of the form of vasculitis, is about 20%. So it's pretty significant.
What about patients with a central nervous system involvement?
You know, that's a question that comes up a lot, and its CNS involvement was in the original version of the five-factor score, but apparently in the analysis, it fell out when they looked at this again several years ago. So it's certainly something that concerns us and something that I would definitely consider cyclophosphamide for, but for mathematical reasons, it's no longer part of the five-factor score. At the end of the day, it's hard to look at a patient with CNS manifestations, though, and not offer them cyclophosphamide. So I think it's a distinction between the old five-factor score and the new five-factor score, but it's not one that would necessarily steer us away from using cyclophosphamide in that case.
Okay, really, really important. So what you're saying is our first goals are really to induce remission in our patients, and we do that with corticosteroids in everybody. And then in patients who have more severe disease, as demonstrated by any of these factors in the five-factor score, particularly older age, cardiac, renal, GI involvement, for those patients, you really want to consider some type of induction therapy with a drug like cyclophosphamide. So we've talked about induction of remission. Now I want to focus a little bit about maintenance on remission. I think it's important to recognize that our goals are really because of the side effects of corticosteroids. And you said rheumatologists love corticosteroids. They love giving corticosteroids. But I bet you that most rheumatologists don't love the side effects of corticosteroids that include cataracts and glaucoma and osteoporosis and weight gain and increased risk of stroke and cardiac disease. So for maintenance treatment, for maintenance of remission, our goals are to facilitate corticosteroid withdrawal, to maintain remission, to keep patients out of the emergency room, to continue to prevent relapses, any new appearance or worsening of clinical EGPA manifestations. So what are some of the therapies that are primarily used in EGPA maintenance of remission?
So again, you think about patients in terms of severe versus non-severe disease. For a patient with severe disease who is treated with cyclophosphamide, you're certainly not going to want to leave them on cyclophosphamide for longer than, say, 3 or 4 months. So then the question is, what do you do with those patients? And the answer generally is to transition them to an antimetabolite therapy. Something like a methotrexate or azathioprine would be pretty standard, and most of those patients remain on those drugs for at least 2 years, but often a lot longer. For patients who are initially treated with rituximab, you could certainly use that strategy. You could transition them over to a drug like methotrexate or azathioprine. But in rheumatology, it's becoming even more common just to continue to use rituximab for remission maintenance as well. So for those patients, they might receive a pulse of rituximab at 500 milligrams every 6 months. And for the vast majority of patients who have vasculitic manifestations with ANCA-associated vasculitis, that's enough to keep their disease under control. Now, for patients with non-severe forms of vasculitis, because those patients are starting out with more mild therapies, for the remission maintenance phase, they'll typically just stay on those therapies. So for a patient, for example, who starts out on methotrexate for remission induction, they might remain on methotrexate for the remission maintenance phase as well. And the same is true with azathioprine or many of the medications we might use for those patients.
One of the newest strategies that has emerged over the last several years has been the implementation of trying to target the eosinophil. And the way that's been done most recently is by targeting interleukin-5. IL-5 is a cytokine that's predominantly involved in the maturation, proliferation, and activation of eosinophils. And so over the last several years, there have been several therapies that have targeted IL-5 or its receptor. We participated in a study that was published in the New England Journal of Medicine a few years ago that evaluated the efficacy of targeting IL-5 with a drug called mepolizumab. Now, mepolizumab is a monoclonal antibody that targets interleukin-5. It's been approved for patients with eosinophilic asthma since 2015. But we decided to treat patients with EGPA with a higher dose of 300 milligrams once a month to see whether it would achieve some degree of efficacy given the importance of eosinophils in EGPA. So what did we find? We randomized patients to get either mepolizumab 300 milligrams once a month or placebo in patients who had relapsing or refractory EGPA who were on at least 7.5 milligrams a day of prednisone or equivalent. And our goal was to identify the proportion of patients who were able to achieve remission, which we defined as getting down to 4 milligrams or less of prednisone and having a Birmingham vasculitis score of 0. What we found as the primary outcome was that 53% of patients treated with mepolizumab were able to achieve this degree of remission. And importantly, one of the other key attributes of this therapy was its ability to facilitate corticosteroid withdrawal and to prevent relapses. In this study, mepolizumab demonstrated the ability to reduce relapses by over 50%. And that was despite the fact that patients treated with mepolizumab reduced their corticosteroid dose by about 50%. In the clinical trial, patients treated with mepolizumab were able to go from 11 milligrams a day down to about 5 milligrams a day by the end of the 52-week study. Whereas patients treated with placebo stayed on about 11 milligrams a day throughout the 52 weeks. Importantly, one of the issues that comes up is can we get patients off of corticosteroids? And what was demonstrated in this study was that 19% of patients with mepolizumab were able to reduce their corticosteroid dosing completely down to 0 milligrams per day. Only 3% of patients treated with placebo were able to down to 0 milligrams a day. Another important thing that we did in a post hoc analysis, we said, well, while 53% of patients were able to achieve remission, there were other patients who weren't able to achieve remission, but were able to have benefit in terms of other outcomes. So we looked at the proportion of patients who were able to either have no relapses over the course of a year, or who were able to cut their corticosteroid dosing by 50% in the study, even if they weren't able to get down to 4 milligrams a day. And what we demonstrated was that over approximately 8 out of 10 patients were able to achieve one of those 3 outcomes, either achieving remission, cutting their corticosteroid dosing in half, or having no relapses over the course of the year. And this is really important. The other important thing to recognize with this therapy is that it's a relatively safe drug. There was no significant difference in patients treated with mepolizumab versus placebo in terms of adverse effects. So Phil, let me ask you about your utilization and your perspectives on mepolizumab. I know that this therapy is primarily used in the asthma patient population, but how has it been received in the rheumatology practices?
Sure. So the first thing I'll say is that the old saw in rheumatology is that by the time you develop vasculitis with the EGPA, so by the time you develop a manifestation like monorized multiplex, for example, the asthma goes away. And that's just not true. I think that is true for a small number of patients. I've actually seen that happen to some patients, but I think for the vast majority of patients with a diagnosis of EGPA, the symptoms that really continue to nag at them are symptoms that affect the respiratory tract, things like chronic asthma that are hard to get under control without chronic glucocorticoids. And the other thing I'd mention about mepolizumab is a reduction of prednisone dose down to 5 milligrams may not seem like a lot, but if you think about that 20-year-old patient who was just diagnosed with EGPA, who might have faced taking 12 milligrams of prednisone for the next several decades, you can see what a gift it is to be able to get that patient down to a pretty low dose of prednisone chronically. So I think for patients like that, patients who have got chronic asthma, patients who have got chronic sinusitis, even nasal polyps, all of which are very common manifestations of EGPA, I think mepolizumab is great. I'm still a little bit hesitant to use it to treat the vasculitic manifestation. So if I have a patient who comes into the hospital with glomerulonephritis, chances are I'm still reaching for a drug like rituximab or cyclophosphamide. But it doesn't mean that I wouldn't also offer them mepolizumab at some point to keep their other symptoms under control.
Yeah, one of the shortcomings of this study was that it focused on patients who had relapsing and refractory disease. It wasn't studied in patients who had new onset disease. It wasn't studied in patients as an induction therapy. Patients who had the most severe disease, life-threatening disease, were actually excluded from participation in the study. So I think that's an unanswered question. And the potential role of anti-IL-5 in those patients really is unanswered at this point. But I think for patients who have eosinophilia as a key component of their underlying disease, as most of these patients do, there is a strong rationale. And when I balance actually the potential for efficacy versus safety compared to some other therapies that are utilized for induction, I wonder whether or not mepolizumab could be utilized in that setting. Of course, we need some data, we need some evidence to prove that hypothesis, because what you're doing with drugs like cyclophosphamide is ultimately you're just suppressing the bone marrow, and therefore that's the important means to suppress the eosinophils that we believe are causing some of the tissue damage. Another thing that I want to bring up is really how this space is evolving a little bit. And in terms of some of the future directions, mepolizumab is the only drug that's actually approved for maintenance of remission and prevention of relapses in patients with EGPA. But there are other IL-5 targeted therapies that are in development for asthma and for EGPA as well. In asthma, we already have approval of not just mepolizumab, but also reslizumab and benralizumab, which is a therapy that targets the IL-5 receptor and can result in depletion of eosinophils through not only by blocking IL-5, but also by inducing antibody-dependent cell-mediated cytotoxic effects that kill off the eosinophils. Currently, there's a phase 3 study comparing head-to-head mepolizumab to benralizumab. It's called the Mandara study, and results will hopefully be available in the coming year. Another interesting and exciting molecule is a therapy called depemokimab, which is another anti-IL-5 therapy, but it has a much longer half-life, and it's administered every 6 months. There's also an ongoing depemokimab in EGPA study, and hopefully we'll find out about those results in the next few years. So let me ask you another question. How do you monitor your patients longitudinally?
Sure. And the first thing I'll say is that it's important to fall back in clinical medicine. I think for patients with EGPA, it's important that you see them on a regular basis because often you're the only physician they're going to see who actually understands all the manifestations, not only of the disease, but the side effects of the drugs that they're taking for the disease. And so your involvement remains important even when the patient seems to be doing pretty well. With regards to routine laboratory monitoring, let me just mention that a lot of people like checking ANCA titers on a regular basis. And I don't want to discourage that practice, but I think you're going to find it a lot less informative than you think it should be. The things to notice about ANCA titers is they often will be affected by the dose of glucocorticoids that you're giving to the patient. So it's not uncommon to see up front that when you treat a patient aggressively for their first diagnosis of EGPA, that the ANCA titer goes away, which makes everyone feel good. And then you notice that the ANCA titer starts to creep back as the steroids are tapered. Again, I really think that's a steroid effect and doesn't necessarily mean anything in terms of disease activity. And there are data looking at this, and an increase in MPO ANCA titer in some studies does indicate there's a higher risk of relapse. I just think for a lot of patients, it just ends up being noise. Now, I do think it's important to monitor an eosinophil count. One of my colleagues likes saying that it should be illegal to get a CBC without getting the eosinophils checked at the same time. And I kind of have the same philosophy, so I think that's important to consider. I'd also mention looking at the patient's urine. And my personal practice is I get a urinalysis every time I get any other lab tests. And what I'm looking for is evidence of glomerulonephritis. And in a patient with a history of cyclophosphamide exposure, I'm also looking for evidence of hemorrhagic cystitis, which might not occur initially, but hemorrhagic cystitis or bladder cancer can actually be a late effect of exposure to cyclophosphamide. I think getting that urinalysis on an automatic basis at least ensures that once in a while you're considering these possibilities, and you're making sure that a patient doesn't creep up on you in terms of new disease manifestations. I think with regards to other recommendations, it's important again to monitor for corticosteroid toxicity, which is cumulative. So even though you don't see it up front in that first year, you might notice several years later that some things have crept into your patient's problem list. I also think it's important to get pulmonary function testing on a regular basis, which the patient's other providers might not consider unless they have a pulmonologist involved in their care.
What do you do when there's a dissociation between lab values and symptoms? So if a person comes in and who's asymptomatic, but their eosinophil count has crept up or their SED rate and CRP have crept up, how do you approach those kinds of patients? Is it that those patients are poor perceivers, or can patients have underlying inflammation and that's okay? Do you increase their dose of corticosteroids in that setting, or what do you do?
I try very hard not to treat lab tests. So if I notice that the ESR is creeping up a little bit or the eosinophil count is creeping up a little bit, I might see the patient more frequently just to monitor them, but I'll try not to increase their corticoid dose in particular unless I see a real reason for it. So in the absence of symptoms, I'll probably just watch the patient a little bit more closely.
Yeah, I think that's my approach as well. I try to follow them clinically, but I tell the patients to be much more vigilant for any new signs and symptoms of disease and to contact me with anything that's new, any new neuropathy, any worsening shortness of breath. The other things that I do is I check pulmonary function tests in my patients just to keep an eye on their asthma. And depending on what other organs are involved, I may periodically also monitor their underlying disease with other imaging techniques. So if they have any new shortness of breath, I'll get a chest x-ray. If they have a history of prior infiltrates on chest x-ray, I might get a CAT scan. I might monitor cardiac function with echocardiogram and or cardiac MRI, depending on the circumstances. So let's shift gears a little bit. And I just want to ask you, how do you manage patients who relapse, patients who come in with increasing symptoms and they're not doing as well from one perspective or another? They either have more shortness of breath or evidence of new vasculitis, despite the fact that they're on one therapy or another on top of corticosteroids.
Sure. So there's an expression, let the punishment fit the crime, and I think it applies to the management of relapse. And honestly, this is one of the things that really confuses providers, I think, because it's not necessarily just one therapy that will work for all patients with EGPA. So for example, with a patient with a severe relapse of EGPA, you'd probably again consider drugs like cyclophosphamide and rituximab. Now, in this particular scenario, we do tend to lean a little bit more heavily on rituximab because it's reflects a reluctance for us to expose to a patient to cyclophosphamide more than once in a relatively short period of time. The other thing to note is that there are some data indicating that initial treatment with cyclophosphamide actually primes the pump, and that patients who are exposed to cyclophosphamide previously have an even better reaction to rituximab for remission induction. So it makes us even more prone to consider rituximab in those cases. Now, for patients with non-severe disease, you might want to consider what you've been doing in terms of disease management. I think for a lot of patients, what you'll notice is that you've been tapering their medications. So it's not uncommon for a patient who's in remission on 25 milligrams of methotrexate, for example, to be tapered down to 20 milligrams and then 15 milligrams. And if that's the case, it may just be that you need to back up. So you may just need to increase that patient back up to 20 milligrams a week of methotrexate in order to recapture that effect. Now, for a patient who's already been on maximal therapy, who is then having a vasculitic manifestation, you might want to consider transitioning over to another agent. And unfortunately, guidance in selecting what that agent should be is a little bit limited. I would say that for patients with vasculitic manifestations, crossing from methotrexate to azathioprine or mycophenolate mofetil probably makes a lot of sense. I think for a lot of patients, though, what you're going to notice is they're really having inflammation of the bronchopulmonary tract, and they'll have features like refractory asthma, for example.
Are there other treatment options that are considered second-line therapies that you've utilized or that have been reported to be utilized that have some efficacy?
Absolutely. So the first thing I'll mention is omalizumab, and Mike, correct me if I'm wrong, but omalizumab is a drug we used to have a lot more enthusiasm for than we do now. Are you using omalizumab for any of your patients?
So omalizumab is a monoclonal antibody that targets IgE. And IgE is involved in mast cell activation and the allergic inflammatory response. And so it was initially approved in 2003 for management of patients with allergic asthma. And we continue to use it to this day. There are very limited data in patients with EGPA. However, there have been some case reports of some efficacy in patients who have an allergic component of their disease. And so for those patients, it may be considered. That being said, there are a lot of newer therapies that are being utilized that have been demonstrated in randomized, double-blind, placebo-controlled studies to have greater efficacy for maintenance of remission and prevention of relapses. But what other therapies have been tried, and do you have any experience or substantial experience utilizing some of those therapies in those patients?
Sure. So the first thing I'll mention is that there are medications like hydroxyurea and interferon alpha that come up for discussion, but I think really their role has been in the treatment of the idiopathic hypereosinophilic syndromes much more than with EGPA. And I'll mention as an aside that interferon alpha, even if it were to work for patients with EGPA, it's an incredibly hard drug to tolerate, and I don't think many patients would stay on interferon alpha therapy for long, even if it was efficacious. Now, for the other medications that you might see on this list, it would include things like IVIG, plasma exchange, and leflunomide. Those are medications that we really use more generally for other forms of vasculitis, for which there's some limited data supporting its use for EGPA as well. Now, leflunomide is similar mechanistically to azathioprine and methotrexate. So it ends up being a medication we'll go to when azathioprine and methotrexate are not feasible, often for technical issues like LFT abnormalities. We might consider leflunomide in those cases. Now, at the other end of the spectrum, IVIG and plasma exchange are often reserved for very ill patients with vasculitis. I will say that plasma exchange has largely fallen out of favor. So if you're seeing a patient who has an ANCA-associated glomerulonephritis with end-stage renal disease or CKD5, we might still consider plasma exchange, but plasma exchange really being limited to that particular group. Regarding IVIG, I think that most frequently you'll see it used in an ICU setting where you're concerned about a severe EGPA flare, but you're also concerned about the concomitant risks of infection, and you're looking for a medication that might help treat the vasculitis without increasing the infectious risk. And that's often when we start leaning on drugs like IVIG.
There are some case reports of success with IVIG in patients who have neurologic manifestations, actually, as you know. What about use of mycophenolate? Have you utilized that at all in your practice as a steroid-sparing agent?
Yeah, I've definitely used mycophenolate mofetil, and in clinical studies of ANCA-associated vasculitis, it seems to be very good for remission induction of patients, so almost as good as cyclophosphamide actually for a select patient population. I think the main downsides of mycophenolate, frankly, are cost and dosing. That for most patients, mycophenolate mofetil will be 2 to 3 pills twice a day. And the cost is significantly greater than it is for methotrexate or azathioprine. So for many patients, one of those issues become a problem.
Right. And one other question I wanted to ask you relates to how do you address some of the potential steroid side effects, such as the risk of osteoporosis? Do you use prophylactic therapies in any of your patients?
Yeah, absolutely. And osteoporosis is particularly important because we know that the majority of bone loss that occurs in patients who are treated with glucocorticoids really occurs during the first few months of therapy when the steroids are the highest. And unfortunately, that's the time where it's hardest to introduce bone replacement therapies because they're so confused by the glucocorticoids and the other medications that we absolutely have to use that adding on the calcium and vitamin D discussion often is overwhelming. But I think for patients who are treated with glucocorticoids, you definitely need to think about bone health. Calcium and vitamin D right off the bat is probably necessary for the vast majority of patients. I think that in addition to that, medications like alendronate would be important to consider as well, especially if the patient already has osteopenia before you institute use of steroids. With regards to the other side effects, I think that it's important to just consider them proactively. You mentioned weight gain before, which seems like a nothing side effect until you've put on 20 pounds and you realize that now you have to drop it. The issue with weight gain and with sarcopenia is they work hand in hand. So steroids not only make you gain weight, but they also cause muscle atrophy. So they make it even harder to get that exercise that you probably need in order to keep the weight off. Things like cataracts and glaucoma require routine eye examinations. It's important to consider also that patients who have other risk factors for cardiac disease, that glucocorticoids add to that list. So you want to be proactive about that as well.
Don't forget to treat asthma, by the way. So I see a lot of patients who will continue to have respiratory symptoms and asthma symptoms. So continue to use bronchodilators, continue to use inhaled corticosteroids. It's okay to use leukotriene modifiers as well. And also for patients who are on higher doses of corticosteroids, we generally add on, if they're on 10 milligrams or more, we add on some sulfa drugs for PCP or PJP prophylaxis as well. So I think we've learned a lot today, Phil. We've had a great discussion about treatment of EGPA. Let's review our SMART goals for this activity. And those are specific, measurable, attainable, relevant, and timely goals. Stepping back, we want to consider individual patient disease severity and specific organ involvement when selecting treatments for EGPA. I think it's important to look at the underlying mechanism of disease in those patients. If there's primarily eosinophilic inflammation, consider treating with anti-IL-5 therapies on top of corticosteroids. If there's evidence of anti-neutrophil cytoplasmic antibodies or other antibodies like IgG4, then one may consider rituximab as an add-on therapy on top of corticosteroids. Obviously, for patients with severe disease, we need to be very aggressive to try to prevent life-threatening or organ-threatening disease and consider the use of immunosuppressants, particularly for induction of remission and for prevention of relapses. Therapies like cyclophosphamide, methotrexate, mycophenolate, and azathioprine can all be utilized as steroid-sparing options. Thanks again for your attention, and thank you again to my colleague, Dr. Phil Seo, for joining me today for our discussion. Take care, everyone.